evening or good afternoon, everybody. This is our pleasure to start with you again with the Dubai Shoulder webinar. Today we have two of the eminent speakers coming from USA. We'll talk about today the shoulder arthroplasty in young arthritic patient. Professor Anthony Romeo, who is the former professor in Rush University at Chicago, and now he's moved to New York. And Dr. Samer Hasan from Cincinnati, both of them will give us a nice talk today about shoulder arthroplasty in young active patients. It's my pleasure also to welcome my colleague, Dr. Ali Maqdes from Kuwait, who will co-moderate this session with me, and he will start introducing one of the cases for a discussion. Welcome, Dr. Samer.
Great to be here. It's honored to be a part of this program. Thank you very much.
Thank you very much for accepting our invitation, and thank you very much for joining us today. I will leave the introduction.
What I'll do is to get everybody up to understanding what is such a case. I'll just take you through 2 minutes for a case that I have dealt with, and believe me, is one of the hardest cases to treat. Can you see my screen?
Yes, yes, Ali, we can see it.
Okay.
Yes, I can see it.
Exactly, perfect. So this is a case that I faced in my practice a couple of years ago when I was in training back in France. And this patient is actually a citizen of my country who was treated with my mentor back in France. So I had the chance to follow this patient between the continents. And it's a very interesting case of a 39-year-old car mechanic who had no relevant medical history before. He's right-hand dominant and complains of his right shoulder with no previous injury to his shoulder. He's complaining of progressive insomnious pain that is waking him from sleep and disturbing his work. He cannot really do everything at work, and he's not very happy with this sort of shoulder. And he's asked for a lot of treatment, and throughout the years has had a lot of treatment. So I would just like to show you that he has a good range of motion with no signs of rotator cuff tear, which can be seen on that image on the axial cut, where you don't see any fatty infiltration, maybe a little bit on the infraspinatus posteriorly. Sorry about these images, but they were 9 years ago. So bear with me, this is what I could find. This problem takes a while. So you see that on the plain x-rays, he has a small osteophyte on the inferior part of the humeral head with a small narrowing of the shoulder joint, the glenohumeral joint. On the axial views, it's what I call a posteriorly subluxed joint with maybe a B2 for me. I don't know if everybody agrees. And on the CT scan, showing no major fatty infiltration or signs of rotator cuff tears. So he failed all his injections and his physical therapy and his treatment, and we're in a corner here on what to do with such a patient who's really demanding, young and active, and wants a treatment for his shoulder. Believe me, this is one of the most complicated cases you can face. I would pass now the slide back to our guest speakers, who will start talking about the management of such a case. Professors.
Okay, thank you, Ali.
Thank you very much. That was a great introduction to the challenging problems that we face with our young individuals who have arthritis. It seems like a disease that we normally think about when we get older, 60 and older, but we see more and more young patients who have these challenging problems like we just saw, where the humerus is not too bad, but the glenoid deformity is very challenging, and we're not really sure that we know exactly what the right answer is even today. There are many ideas. So we need to think more about these young active patients that have arthritis, and we need to separate them out from many of the discussions when the experts talk about treating arthritis of the shoulder with an implant. Younger patients require us to think a little bit harder about why they have this problem and what we can do. We know that this arthritis problems affects all of us, our abilities to do activities, athletics, work. It causes pain, and it makes people dependent on society. So we want to have better answers. We wrote a paper about this a few years ago to try to define some of these issues. And in this paper in the Journal of the American Academy of Orthopedic Surgery, we started a little bit earlier than arthritis to the point that we have to consider a replacement. So even cartilage injuries can be a problem that can be very uncomfortable in the shoulder, less so than what we see in the knee, but can still be a real issue. And we borrowed a lot from the knee to try to treat these somewhat pre-arthritic conditions. And we'll talk a little bit about that issue. So the conditions in younger patients are actually more diverse. It can happen after surgery or trauma. It can happen if they have an osteochondral lesion, which is rare, but can go along with avascular necrosis, which in our country, 50% of the time is due to the medical treatment of a variety of medical conditions with high-dose steroids, like non-Hodgkin's lymphoma or inflammatory diseases. And this can cause hip and shoulder avascular necrosis in young people and can be a challenging problem. Chondrolysis is another issue that we have seen. It's gone down a lot because we identified some of the more noticeable causes of this condition, and Dr. Hasan will speak to that. And of course, osteoarthritis, and then these focal defects. And so when you look at a variety of patients under the age of 60, just by age alone, you don't really know what you're going to get. You have to spend some time with a history, an exam, and x-rays. It could be straightforward arthritis like we see to the left. It could be avascular necrosis like we see in the center. It could be some form of cup arthropathy if they've had significant rotator cuff disease at a young age. And this has been pointed out to us by Dr. Maqdes and the team at the University of Washington. When you look at the pie chart on the left, you see over the age of 50, it's heavily dominated by degenerative.
Sorry to stop you. Can you share your slides?
Again, just briefly going back, what you see in young people can be quite variable. So age alone is not a clear indication of what is presenting in your office. We learned from Dr. Maqdes and the team at the University of Washington that patients over the age of 50, as you see on the pie chart to the left, predominantly come in with degenerative joint disease. And that makes up a large portion of all patients who have treatment for arthritis. And unfortunately, because of that, it biases the results and the outcomes towards this specific group of patients. But when you look at patients under the age of 50, as you see to the right side, you see there are many more diagnoses that can present to us with arthritis, but for a different cause. And therefore, most studies show it's difficult to get the same results in younger patients that we get in older patients. It's not just a factor of activity, which many people think is the case. It's because the disease can be different and the challenges can be quite different in treating them. So we have to keep thinking about better ideas. There are a number of non-operative treatments for shoulder arthritis. Physical therapy is still valuable. If a patient gets a stiff, painful shoulder and we can loosen it, that can reduce their pain. Even if the x-rays look terrible, they can get better. We use anti-inflammatory medications. We still use cortisone as our primary injection into the glenohumeral joint to alleviate their pain. Oftentimes, early in the disease, it can last for a very long time. But towards the end, if we get 3 months, that's considered valuable. And people are trying other medications such as hyaluronic acid and orthobiologics. We know in the knee that the injection of platelet-rich plasma seems to have a similar effect, but a longer lasting effect than some of the other treatments. Much to learn in the shoulder. We don't really know how well the orthobiologics are going to play a role. And I don't know what it's like in the variety of countries that are represented today, but I can tell you in our country, this is not covered by our medical insurance, and it's a very expensive treatment. So most of the studies are biased towards patients who want to have this treatment and who have the money to pay for it. So there's a very strong placebo effect using this, and we have much to learn as to exactly what is the right biological treatment to try to help them. We usually start out with an injection of corticosteroid and physical therapy if they're particularly uncomfortable. Some people have tried hyaluronic acid, but the studies are not very good. And again, there are some experimental treatments that are available. We also know in some work that we've done in others that you have to be careful with cortisone injections because it changes the environment within the joint and it can reduce the ability to resist infection. In fact, what we found is that patients that had a cortisone injection for arthritis that we were trying to treat without a surgery, but then said, I'm very miserable, I need to have surgery, and that was done within 3 months, the incidence of infection was significantly increased. So we now do not perform surgery on someone who has had a cortisone injection in their shoulder until at least 3 months have passed to avoid infection. We think that's very important, and there's a number of studies that have shown that. There are a variety of treatments available for shoulder arthritis, as we know. We'll talk a little bit about arthroscopy. The reverse prosthesis, of course, was designed for our older patients. It was not supposed to be a functional device. It was only designed initially for primarily women, because in France, the demographics were that 75% of the people getting the surgery were women. And it was after the World Wars, and so there was a lot of widows. And the device was initially designed just to be able to raise up your arm and to wash your hair and to feed yourself. We ask much, much more now of our reverse prosthesis, and we see doctors using this at a younger age. So what role would that have in a young person? We certainly would like to avoid something like this in the 39-year-old patient that you just saw. And then what are we doing with standard shoulder arthroplasty? We want to keep in mind, though, there are a group of patients who have some arthritis, but not really bad. And we have to decide whether we can do other things besides replace their shoulder joint. So age is important, and that helps us because we know if we're using some type of biological treatment, it doesn't work very well after the age of 50 and certainly not after the age of 60. We have to be aware of their symptoms and how we can treat them and what prior treatment they've had. And then we have to be defect specific. In other words, if there's a local area that's been injured, but the rest of the joint is good, there may be things that we can do early to intervene to prevent the eventual progression to post-traumatic arthritis. So we want to keep that in mind, especially with our instability patients. And we've thought about that when we go and we see a chondral defect, and it's just incidental. We're doing an arthroscopy because the patient has symptoms, then we want to treat that arthroscopically. And we see there's a cartilage defect. We normally just debride it and leave it alone at that time. If there is, in fact, a cartilage defect on both sides of the joint, then, and it's a young patient, we think about what can we do to try to solve that on both sides of the joint. And there's not a whole lot of options available, but I'll talk about those after Dr. Hasan starts up in just a minute. And then if it's a small lesion, people have used microfracture. It doesn't work as well in the shoulder. Putting little holes in the bone in the shoulder is okay on the glenoid side, but not on the humeral side. That does not work well. And so now what's happening is if there's a specific defect, we can take grafts made of bone and cartilage and fill those in. And I know that those are not available in many parts of the world, but this is what we're trying in the United States and in North America, because we have these grafts, and remarkably, they actually do pretty well. And instead of little tiny grafts, using a larger piece of bone and cartilage actually seems to work well and could be a good option for your younger patients who have a bone or cartilage injury after instability events. If they're large lesions, of course, then that's what we always use in that setting. So there's a variety of different options, and one of them is arthroscopy. Some of them is biological resurfacing. Some of it is just replacing the side of the humerus. Some is to place the side of the humerus, but treat the glenoid without an implant. And then, of course, a shoulder replacement. So I just wanted to start with some of those ideas so you start thinking. So you've heard the case report, 39-year-old. We'd really like to stay away from arthroplasty if we can. I've given you some ideas of some options that we might do, and we'll go into further detail in a minute. But I'd like Dr. Hasan to sort of really point out to you why it's so important to understand exactly what the underlying cause of the arthritis is in these young patients so that we make sure that they get the proper treatment. So I'm going to hand over my screen to Dr. Hasan and let him continue from this point.
Thank you very much. That was a great segue. And I'm going to transition now. So can you hear me? I hope
Yes,
you can
we
hear
do.
me. And so
Yeah,
I'm going
we
to
do.
move on and so give a little bit of my take. These are my disclosures. We've covered the objectives. And just to give you an idea, I perform prosthetic shoulder arthroplasty in young and active patients. My youngest underwent resurfacing hemiarthroplasty for chondrolysis, a condition that Dr. Romeo touched upon. And my youngest anatomic total shoulder arthroplasty patient was that same patient 3 years later, because we know now and didn't know very well then that it is an inflammatory type of a condition, much like rheumatoid, and you really have to address both sides of the joint. And just to give you an idea, my oldest anatomic total shoulder arthroplasty patient is 70 years older and reverse at 96. So we have an 80-year spread, and we can't take care of these patients the same way. They're vastly different. So Dr. Romeo touched upon the challenges, and really the issue here is the precise definition is evolving. You know, most previous reports use thresholds of 50 and 55 years, even when they talk about young patients. But as was presented by Dr. Maqdes, we know that patients much younger than that undergo prosthetic shoulder arthroplasty. And so it remains unclear if we can take published results that we're looking at cohorts of around age 50, which are young as well, and extrapolate those to patients that are 20 years younger. And at the same time, we have older patients that are exceptionally active and may have the expectations and demands of a much younger patient. And so, you know, conversely, some young patients are physiologically old. Dr. Romeo alluded to steroid use. This is a patient with severe osteonecrosis at age 38. And his tuberosity was like butter. It literally kind of peeled off. We had to suture it. So I did an anatomic total shoulder replacement, but actually used a inset reverse component, thinking that I may literally have to revise his shoulder to a reverse. We didn't have to do that, but these are the types of concerns. So again, it's a heterogeneous population, and it's really hard to generalize. To make matters worse, these patients often have very high expectations regarding their return to work and or sport. They place great demands on their shoulders, and therefore there is potential for excessive loading and motion that may result in accelerated wear and early failure, especially on the glenoid side, which has been a focus in terms of our challenges in treating these younger patients. Now we have to choose implants selected for durability, and some of the emerging implant options that are available are simply too new to have long-term follow-up, and so one never knows until after the fact. The life expectancy of our younger patients is much longer, obviously, so they may be staring at the potential for not just one revision, but potentially more than one revision. And so we have to be thinking about ease of revision and convertibility as well. The results in younger patients, by and large, have not been that good, even though there's improvements in outcome. If you look at patient-reported outcomes or satisfaction scores or range of motion, it's a highly effective operation. John Sperling has looked at the Mayo database on multiple occasions, quoting published survivorship of 85% for total shoulder at 20 years. Those are very good results, and yet when you ask patients, about half of these patients remain dissatisfied because, again, the challenge is matching expectations in some of our younger patients. The other thing, too, is we know that, regrettably, because of the high demands and potential for loading, the risk of revision, the rates of revision are actually higher in younger patients. When you least want it, you tend to be faced with the prospects of more frequent revisions, again, in a younger cohort. And this has been borne out in the Australian National Registry data, which has a 99% capture. So if you want to look at registry data, there's probably none better. And it shows that the percent revision of primary anatomic total shoulder is actually higher for the younger decade, those younger than 55. And then with each consecutive age group, 55 to 64, 65 to 74, and so forth, the rates are actually lower. So the other thing is these young patients don't just present with osteoarthritis. And so you have instability or dislocation arthropathy. Some of these patients in the US, we see these patients, they're often young, they may be underinsured or uninsured. They'll come to us after hundreds of instability episodes. And they've got not just large Hill-Sachs lesions and glenoid bone loss, but actually outright arthrosis and cartilage loss, and sometimes it's global. When we repair them, sometimes we tend to make them tight. There was a whole slew of repairs, the Putty Platts and so forth, that were subscap advancement type procedures that were intended to limit external rotation. But what happens, the contact forces go up, you have obligate translation towards the back of the shoulder, and you get accelerated wear. Osteonecrosis, again, we've both touched upon it. Inflammatory arthropathy, including rheumatoid, perhaps less so because of the onset of disease-modifying anti-rheumatoid drugs would have really been transformational in managing these. And then chondrolysis, which I have a keen interest in because of a large cluster of these patients that we took care of in Cincinnati. So here's that patient with osteonecrosis. I'm not going to show those videos again. And this is how we treated him. Capsulorophy arthropathy. This is a patient who presents 25 years after a Bristow with profound deformity and on the glenoid side, significant glenoid wear and bone-on-bone arthritis. Some of these patients have enormous large inferior humeral osteophytes, which can be quite challenging to remove, and yet very rewarding because these patients will do very well with good surgical care. Chondrolysis is a rare and devastating condition that's characterized by rapid, almost fulminant cartilage destruction associated with high levels of pain and stiffness. In the United States, we had a large cluster of these, probably several hundred in the United States, about 15 years ago because of the use of these intra-articular pain pump catheters infusing chondrotoxic local anesthetics because they're acidic and they tend to be toxic to the cartilage. But that has come and gone, fortunately. We don't see that much often anymore, but we do have cases where suture anchors can be placed prominent, and whether or not they're metallic, they could still do a lot of damage. You have occasional excessive use of intra-articular heat, so thermal wands, especially in a closed arthroscopic environment. These can be potentially harmful. This is, again, a patient who is still not 20 years old at the time of his resurfacing hemiarthroplasty. Here's another patient, again, with anchors for posterior labrum repair. And if you look at the panel on the top right, you can see the cause and effect. That humeral head is flat because of the wear of these prominent metal anchors just grinding away at that bone. And of course, you get bipolar disease as a result of that. And as Dr. Romeo alluded to, there are non-prosthetic treatments. There are a variety of arthroscopic and open interventions. And I think he's going to talk more about that in just a little bit. But the long-term effectiveness and reproducibility has been questioned, especially in patients with advanced disease. This is actually work out of Rush. And we know further that some types of glenohumeral arthritis, such as chondrolysis, tend to be refractory to non-operative and arthroscopic intervention and frequently end in the requirement for needing some type of shoulder replacement. So if you look here at this flow chart, these were two groups of 20 patients with chondrolysis that I took care of. They were slightly different, but both of them, you can see the large number of patients that underwent additional arthroscopic surgeries, sometimes more than one. But at the end, 27 of these 40 patients ended in some type of shoulder arthroplasty, either a resurfacing or a hemiarthroplasty with some type of biologic glenoid treatment or a total shoulder. Again, nearly 3/4 within 5 to 6 years after the onset of the diagnosis. So no matter how hard you try, arthroscopy has its limitations. So I'm going to stop right here and switch it back over to Dr. Romeo.
Thank you very much, Samir. We'll come back to you again.
Thank you.
Dr. Romeo?
Yes, thank you, Samir. One of the audience members asked, how long would you be willing to treat a arthritic shoulder with non-surgical treatment before you decide on surgery? That's a complex question, but in general, what we try to do is treat them as long as possible because remarkably, many patients will have months or even years of a relief of their symptoms. In fact, at this time in our country of the United States, many insurance companies require a documentation of at least 1 year of non-surgical treatment before they will approve paying for a shoulder replacement surgery. So in summary, the answer is not perfect, but we certainly begin with no less than 3 months. And I think most people say up to 6 months or more. But again, our insurance system actually requires us to document at least a year of some form of treatment other than surgery before they approve it. So I think those are important factors. Of course, this is for osteoarthritis, a degenerative, slowly progressive problem, as opposed to fractures or other conditions. Now, we talked about before what are the options are available, and Dr. Hasan started going over some of those. And we did have one question also from the people in the audience about just treating the glenoid alone, and I'll try to address that. So what can we do arthroscopically to try to treat this condition? Well, there is a sort of a camp of surgeons who developed a variety of techniques, and the most common underlying condition that was with some value was stiffness. So surgery is a mechanical procedure. It hopefully has a biological impact, but it's mechanical. And if you cannot document a mechanical problem, in other words, if they have reasonable range of motion, they don't have any sense of catching or popping or a loose body, then doing something arthroscopically is unlikely to make a big difference, just like we've seen in other joints. So the one area of the shoulder is stiffness. Some patients will have arthritis and do well for a while, and then all of a sudden develop an increase of stiffness and pain or loss of motion. And it may be because they're developing a larger bone spur. There may be other causes, but a capsule release has been shown to be helpful. Dr. Millett in Vail, Colorado took this one step further and felt that in some of his patients where he did a release, it wasn't enough. And he thought that maybe some of this was also related to pressure on the axillary nerve coming through the inferior capsule. So he's created a procedure which he calls the CAM, which stands for Complete Arthroscopic Management of Arthritis. And this is a procedure that many surgeons will not do. They feel it's unsafe because you must be comfortable with removing bone at the inferior part of the humerus while you're protecting the axillary nerve during an arthroscopic procedure. This is a very technically demanding procedure. It can be done safely, but it requires some advanced techniques such as retractors on the nerve, holding it out of the way while you're removing the bone. But this is the highest level of what we think we can do arthroscopically. And Dr. Millett and his primarily his disciples, those that have followed him, have suggested you get good results. Many surgeons will just do the release and leave it at that without taking out the bone spur. And so this has been reported in a variety of different areas, but if you look at the algorithm, so glenohumeral arthritis in a high demand patient, we try the non-surgical treatment as we talked about, it fails, what else can we do? If there is not significant glenoid deformity, because one of the factors that is associated with a poor result is a significant subluxation of the humeral head or posterior wear or a B1 or especially a B2 glenoid, arthroscopic surgery doesn't seem to make a difference. So we're getting an even smaller group of patients now, primarily the A1s, A2s. And again, for those of you who are not as familiar, this is a classification that was initially developed by Gilles Walsh from Lyon, France, using plain X-rays and then subsequently 2D CT scans. But the A1 and A2, the humerus stays centered in the glenoid, and the B1s and then the B2, the humerus starts to sublux posteriorly and there's posterior wear. And those are the ones, especially the B2s, that don't do well, and we don't consider the arthroscopic surgery for them. The technique, as I said, is quite demanding. You do see the axillary nerve if you do this correctly. It is possible. There have been anecdotal reports, no published paper, but there have been anecdotal reports of the axillary nerve being destroyed during the surgery. So this is something I think you have to be very careful about considering, but this is sort of what we consider state of the art for arthroscopic surgery. Capsule release, removal of the bone spurs, removal of loose bodies, and if it's valuable, cleaning out the subacromial space. And again, when we looked at our results, we actually had pretty decent results. And what I mean by that, 2 out of 3 patients did fairly well over time, but almost a third of patients would progress to having a shoulder replacement. Some would argue that that's a waste of our healthcare dollars. And based on all of the information we have, that would be true. In other words, if we're not getting a minimum of 5 years out of a surgical procedure for a degenerative disease, we probably are wasting our money overall. Most of these patients in our country come in and ask for the surgery. It's not so much the surgeon says, I think you'll do well, as much as they say, I don't want a shoulder replacement. I'm too young. What else can you do? And that's what makes up the majority of these cases. So again, there's a little selection bias, but it is something we do try in those patients who don't want a shoulder replacement, they're young, and we hope that it helps them. And as I mentioned, it can work out pretty well in some patients. It's primarily a pain relieving operation. It doesn't seem to have a significant impact on function other than the fact that your shoulder works better when it doesn't hurt so much. And again, there's a fairly significant progression to those patients going on to have shoulder replacement surgery. So we don't know for sure scientifically what's the best ones to recommend for. The surgeries can be a little bit dangerous and we have to be cautious. And we use this on occasion for those patients who are young, who want to continue to be very active. They have a humerus that's centered in the glenoid and relatively small bone spur, and we can get years out of this surgical treatment. Sometimes there's a very large lesion of the cartilage, and we have tried microfracture. As I mentioned, on the glenoid side, it has been helpful. On the humeral side, it's what we would call almost a bipolar distribution. Some patients do okay, but some patients actually get worse and become more painful after the surgery. So we're very reluctant to consider this for treatment on the humeral side. And frequently, especially for a lesion this side, if we really are trying to push what we would call investigational work, this is a lesion where we may consider the use of an osteochondral graft if the rest of the joint looks good. If this is just the beginning of a degenerative arthritis, we're probably wasting our time even with an osteochondral graft, but these are some things that we think about. Microfracture alone, we've had good results. We've had 10-year follow-up that suggests good results. Where are the results good? It's when there's minimal joint narrowing, so there's some cartilage left. The defects are 2 centimeters or less, more on the glenoid than the humeral side, and that seems to be helpful. And again, this is another study that was done out in Vail, looking at their series. Again, good results, at least early on in the first 2 to 3 years. It doesn't seem to hurt in many patients, particularly on the glenoid side, but not really sure that it's a very good use of our healthcare dollars for most patients who have this problem. If you have someone who's a high-level athlete who's still in their 30s and 40s, wants to avoid joint replacement surgery, we may try this to see if we can help them out. And then there's been newer ideas, but these are cases where there's only small collections, and we can't say today that this is a great idea. And again, when we look at the cost, these are very, very expensive operations. Sometimes putting in this cartilage and the matrix in the United States, that's an extra $5,000 US for the surgical procedure, just that alone. That doesn't count for the rest of it. And again, we have to be conscious that our society can't afford these things, especially if it's only giving us 1 or 2 years. That really doesn't seem to make sense. For larger defects, for the unusual case where it's a single-sided large defect, such as a traumatic event, we see this sometimes in unusual dislocation. Instead of breaking off and causing a defect, a big defect in the posterior humeral head, they shear off part of the articular cartilage. And we may consider this type of procedure. The results early on were good for about 2 years, but many of these grafts still have trouble staying viable and not collapsing. So again, a bit experimental. As patients start to get closer to 50 and older, metal is going to be much, much more predictable than any type of biological graft. And so we have to make sure we pick the right patients. Where it can work very nicely is where the bone defect is at the periphery of the joint. So here's a Hill-Sachs lesion. This is not that bad, but this is one where the patient had recurrent dislocations after a prior anterior shoulder stabilization procedure and was going to undergo fixation or treatment both on the humeral and glenoid side. And we can take a graft In the past, we've been using these fresh grafts. Again, I hate to keep bringing this up, but it's real. It's a lot of work to have a system that's set up to have these grafts available. And these are very, very expensive. And sometimes metal is a better option and less expensive and works just as well. But again, just to give you an idea of some of the technology, we can take that piece, we can cut it out, we can put it in there and fix that. It does two things. It stabilizes the shoulder from a large Hill-Sachs lesion. Usually these are 25% or greater, and they have recurrence of instability. And then it also creates an articular surface that's nice and smooth. We've actually moved on at this time. Instead of using the humerus, which is a very expensive graft, is we use the talus. And I know that sounds funny, but more than 10 years ago, Dr. Matt Preventure and I put together the idea of using the end of the tibia as a graft to take care of the glenoid defects, and I'll show you that in a minute. And it took us a little while to figure out, well, if it works on one side of the joint, then why wouldn't it work on the other? And sure enough, the talus has an area that fits very nicely with the humeral head. We have done some operations where the glenoid is perfectly normal, but there's a 25% or greater Hill-Sachs lesion, and we'll arthroscopically repair the glenoid lesion, and then we'll open this posterior aspect of the shoulder, and we'll put a graft in place, and we can replace that with a graft and make that nice and secure, as you see here, and that allows us to stabilize the shoulder from both the front and the back of the shoulder, and that's what this looks like. And this patient went on to have no further episodes of instability. So what about other biological reconstruction options? You see this here, and if it was just on the glenoid side, is there something we can do? There are some doctors who have actually gone in and covered this up with a graft. They've used skin. There's a variety of different names for that in the United States, depending on the company, but they've used dermal grafts. People have used synthetic grafts. And remarkably, the results are not really well published long-term. But the individual surgeons often will report very good results. There is the result using the tensor fascial autograft, which was described by Buzz Burkhead many years ago, which has had a better track record and may be considered as a soft tissue reconstruction covering when you're just doing the glenoid side, or when you're putting that on the glenoid side in a young patient and using metal on the humeral side. So we'll talk about that. We tried a bunch of different grafts at Rush and other places to try to see what worked out well. Most of our cases had a humeral replacement because the humeral articular surface was bad, as you saw in that previous video. And then we were trying to get away from the glenoid implants because that's what fails first. And so we thought maybe if we did something biologic on the glenoid side, we'd have an implant system that would last a long time. And we've wondered whether you just have to clean this up. As you see here, this was a technique, again, by Buzz Burkhead, but you'll see the glenoid is definitely arthritic. He reams the surface to get it nice and smooth. He prepares it well, and then he puts a graft over the top, and his graft of choice, as published by Sumant Krishnan, is a tensor fascial autograft. And he published results that are outstanding. Never been reproduced by anyone else. That's not to say that it's not true. It's just that for whatever reason, it worked really well in Dr. Burkhead's hand, and no one else has tried to do this exactly like him in a way that came up with the exact same results. You know, and the results are really actually quite good. If it worked this well, we would probably do it more often. But we did not find the same thing. So you see here that some of it was anterior capsular graft, autograft fasciolata, and then a tendon Achilles graft that he used. We tried meniscus thinking that that would unload the shoulder a lot better, and that might work out well. You put it in, it looks like a cardiac valve surgery when you're done. We sew it into the edges. They didn't work out well, and within 3 to 5 years, most of them have degenerated and a very high giant cell population suggestive of some type of reaction to the material. And this is particularly when you have metal implants in there. So we reported on this. Eric Strauss at NYU was our fellow and reported that within 3 years, the results were already not very good. And within 5 years, they were terrible. And we abandoned this idea and have not gone back to it. So currently, in terms of biologic resurfacing, probably the best results are with a patient's own tensor fascial autograft. And this is done so rarely in the United States, we don't have a modern update in the last 10 years over whether anyone's doing that. The procedure that many people are doing now, which we would consider investigational, is using a dermal graft very similar to a superior capsular reconstruction, taking a dermal graft and sewing it into 6 to 8 places on the rim of the glenoid as a soft tissue reconstruction to try to see if that would help. And so, that's not very clear that that's going to work, but for most purposes, we have abandoned the idea of using these soft tissue grafts because the results at 5 years were always worse than metal and plastic, always worse. And so if anything, we thought about maybe we just don't put anything on the glenoid side, and Dr. Hasan's going to talk to you a little bit more about that. Hemiarthroplasty is a good operation, maybe not a great operation, but it's a good operation. And so it's something to consider. The results are very clear that totals have a more reliable outcome. But again, as I said from the very beginning, most of these reports are in older patients. And in younger patients, we don't have quite the same delineation, but studies like from the Australian registry do still show that hemiarthroplasty does not last as long as a total arthroplasty, even in young patients. And so that's something we always have to keep in mind. We all wish we had this patient here who came in to see me in my office because his physician had passed away who did his shoulder replacements. And he said, well, it's my 25-year anniversary, and I just want to make sure there's no problems I need to worry about. I asked him, do you have any pain? He says, no, I have no pain. What do? I swim every day. What else do you do? Anything I want. And this is his x-rays. So he has a hemiarthroplasty only. It doesn't look perfect, but you saw his motion. We would all be very, very happy to see this. And this gentleman has 25-year results with a centered glenoid and will never have to have another operation on his shoulder unless he has a rotator cuff condition. So why can't we get that consistently? It's not very clear, but again, all of the studies that we've looked at show that a total shoulder is better than a hemi, but we have these cases where some people do really, really well. Dr. Hasan's going to talk about the ream and run. I don't want to go into that too much. I do also use this technique. There are some very important aspects to the technique that you should listen to in terms of how you prepare the glenoid to make sure that this works. There are some publications where it says it doesn't work, but they don't do the operation correctly. And so that doesn't really tell us anything. And we know that this seems to work out well in many patients. Here's an example. This is the problem that I had, is that remarkably, this is a gentleman who's extremely happy with the results of his ream and run procedure. He loves it. He can go back to work. He has no pain, and he thinks this is fantastic. You and I look at the shoulder and say, that's an okay or average result. He should have better motion. He should move easier, but he doesn't care because he has no pain and he can do all of his work and he's very happy. So our ream and run operation may be a very good operation for our younger patients who can tolerate a little more stiffness and a little more soreness and not have to have revision surgery. So it's not for every patient, not for every surgeon or every problem, but Dr. Hasan will talk to you about that and some of the contraindications. I'm going quickly because he's going to cover that for you and discuss when this might be a good idea.
Your arms.
So here's another gentleman.
And then let it come back down.
And he is
now reach behind your head. Just show me behind your head that way. And then do it with the other one. Okay.
So this gentleman had bilateral ream and run procedures. He is a state police officer. He still is involved in military type activities, lifting weights and other things. And he's had both of his shoulders replaced, and he's been back to work now, I think, for 9 or 10 years and is doing very well. Something to strongly consider for our patients who want to do heavy, strenuous activities, who have a good mindset. We call that being resilient. Do not take pain medications and do well. And so that's very important. All of these procedures require some planning ahead of time. And I think it's really important that we talk a little bit about this. And again, I'll let Dr. Hasan cover that better. This is that classification that we're talking about. We do better with A1s and A2s versus the Bs and Cs. We do like to use our radiographs, but also our CT scans. We have the ability to put this into a computer and measure this, look at it in a 3D scan, which really helps us understand it better. And then we can come up with a specific plan on exactly where to put our glenoid in place so that we know that we have it in the right spot. Many of us believe that if you can put it in the precise position in these younger patients, you're going to get much better long-term results. And I think that's very important. And we do these in the beach chair position with special instruments. I won't go through the whole procedure. I'd like to hand this back over to Dr. Hasan so he can talk to you about a variety of these subtle points that I've been bringing up to you. Dr. Hasan.
Thank you, Dr. Romeo. That was terrific. Let me see here if I can take ownership of the screen, and let's see here. All right. So, this is hopefully will be a good segue. There'll be a little bit of overlap, but I think that's healthy. We talked about options. When you talk about on the shoulder arthroplasty, so you've tried arthroscopy, certainly non-operative management if that patient is a candidate for it, but ultimately, when the arthritis is advanced enough or the patients get to a certain point that they're looking for definitive treatment, we offer them some type of prosthetic shoulder arthroplasty option. But it's not just one option, there's several. You can do a resurfacing hemiarthroplasty, which is essentially a cap over the prepared humerus. There's hemiarthroplasty, which can be without glenoid treatment or with a biologic treatment, including ream and run. Then you have anatomic total shoulder arthroplasty, which can be with a stemmed or stemless humeral component, and then with a standard or an augmented glenoid component to address some of the glenoid version issues. And then really a reverse shoulder is a part of our armamentarium, but I agree wholeheartedly with Dr. Romeo that this is something that we try and avoid. We avoid for multiple reasons. One, the kinematics is not as normal. There are some problems that reverse shoulder can have that really don't have a very good solution, whether it's scapular spine fractures, whether it's terminal instability. And although we have very good midterm survivorship with reverse shoulder, we really don't have the data that we can put forth to a 30-year-old or 40-year-old or 50-year-old patient and say, this will likely outlive you. We just don't know that yet. We don't have 25 and 30-year data. And we have a pretty good idea about anatomic shoulder arthroplasties, even with earlier designs, that the majority of them do hold up reasonably well. So resurfacing, again, the indications for me would be humeral head disease, for example, osteonecrosis that has not yet affected the glenoid. Chondrolysis patients may not be a very good candidate, although I have the majority of the patients are doing well, some in their second decade, but I'll submit to you that's more of an inflammatory condition. You've got to have adequate humeral bone stock. You can't have the type of severe humeral deformity. It becomes a little harder to address, but the steps basically are to expose. I think there's a faulty sense that this is a less invasive operation that can be done through small incisions with incomplete management of the soft tissues. And I really disagree with that. I use the same utilitarian delta pectoral approach. I do releases on the glenoid side, even though I'm not doing any glenoid treatment. I preserve the labrum. You still have to see, you have to release the inferior capsule, remove the osteophytes, just as you would for a stemmed implant. Once you identify the center of the head, you drill your guide wire and then you ream with a cannulated reamer over the guide wire just to get a nice sort of uniform hemisphere that'll accept the implant. And you want to get down to cancellous bone and preserve the rotator cuff. And this is what it can look like. Again, the glenoid, you can see the clear space because the glenoid is not affected by this disease. And here's another patient. Again, you see good register of the resurfacing, but again, a thinner clear space here because the glenoid is affected, excuse me. It's just that at age 17, we didn't want to do any glenoid treatment in such a young patient. For me, it's a niche, not the norm. I think I'm just about to hit 1,700 shoulder arthroplasties, and I've done a whopping 60 resurfacing. And I think that's a large number in part because of this cluster of chondrolysis patients they saw that were very, very young with very, very bad disease. And the reality is we don't do this often because the glenoid is rarely normal, as Dr. Romeo alluded to. And although you can do a glenoid resurfacing or an inset glenoid with a resurfacing, humeral head resurfacing, it is harder because your head is still there. You've got to work a little harder to retract and get a good on-face view of the glenoid, or use specialized off-axis instruments to implant a glenoid component. But it is bone conserving, and I would submit to you that in the right patient, it can be a temporizing a measure that doesn't burn any bridges for consideration of a more traditional anatomic total shoulder later in life. So hemiarthroplasty, again, was touched upon by Dr. Romeo. We know that in very good randomized controlled studies that the performance of anatomic total shoulder is superior to that of hemiarthroplasty in terms of avoiding early reoperation, in terms of outcome scores, in terms of a range of motion. There is a little bit added cost. It takes longer. There's a little bit more blood loss. It's going to cost a little bit more because you're putting in a glenoid component, but there's no question that it's the better operation for primary osteoarthritis in general. Now, where it gets a little bit trickier is what do you do about the really, really young patients? John Sperling, again, was looked at the Mayo database, looking at patients who were under age 50 at the time of their arthroplasty. Again, followed long-term, total shoulder is more durable than hemiarthroplasty. Hemiarthroplasty patients have to deal with glenoid erosion. That's often painful, requiring the need for revision surgery. Whereas with anatomic total shoulder, we still have to contend with the potential for glenoid implant loosening, but it's not as common, or symptomatic glenoid loosening, and the need for revision is less common than a raw glenoid being painful and leading to revision. Other problems, and this kind of segues back from Dr. Maqdes' case earlier, again, the problem here is that if you have poor recentering preoperatively and you don't do anything on the glenoid side, there is this potential for posterior instability and a failure to recenter the humeral head if all you do is a hemiarthroplasty. Dr. Romeo touched upon this with biologic glenoid resurfacing. You can use even local graft, like local capsule. Doug Harriman was at the University of Washington many years ago. Would do this in a few cases. Lateral meniscal allograft and acellular dermal allograft matrix are probably the two substrates that have been studied the most. And there have been multiple papers. Hasan, when he was with J.P. Warner as a fellow years ago, found that the results were dismal, high incidence of revision to total shoulder. Mu with looking at Ruben Gobezi and R.J. Nowinski's results, again showing that there were initial improvements in pain and function after hemiarthroplasty with biologic resurfacing, but again, a revision rate of 44% at 3 years. And Dr. Romeo already alluded to the work that Strauss published out of their group, again showing a high incidence of failure, a little bit better with lateral meniscal allograft, but still almost identical to the results published by Mu. So that leads us then to some type of prosthetic glenoid implant. So we're dealing now with a resection of the humeral head, some type of humeral component, stemless or short stem or traditional stem, and then doing some type of a glenoid component. The glenoid component is a key long-term challenge, and it's really difficult to determine the most durable glenoid implant for our young patients. The peer-reviewed literature leaves many questions unanswered because you have to look at practice variations. There are variations in terms of our practice demographics, the type of arthritis, the amount of deformity, our tolerance, if you will, for considering anatomic versus abandoning to reverse. And then, of course, the specific implants that we're dealing with, precise surgical techniques. And then, of course, nothing kills your results like long-term follow-up. And regrettably, a lot of these follow-ups are still in that short to midterm range. Long-term follow-up for these type of procedures has been, by and large, scarce. So if you look at the fixation options for a polyethylene glenoid, you can do keeled versus pegged. I tend to favor multiple offline pegs. That's what's more prevalent in the US, but for many years in Europe, it was typically more common to use a keeled implant. On the fixation, there's been a trend to do cementless or minimally cemented options. And if you're doing an all cementless, you can do metal posts or fluted pegs. Fixation, there are some implant designs that are metal back that can be convertible, but one of the challenges with convertibility is you have to make some compromises in terms of how you orient your glenoid. And also, if you have metal backing, it means that either you're going to have a thicker construct, which may not be the best option for the tensioning of the soft tissues, or you have to have a thinner polyethylene, which may impact the longevity of that polyethylene. And there have been reports of early failure of these constructs. And then there's been a lot of interest in managing the B2 and B3 glenoid with augmented glenoids, that is to say glenoids that have a backside that is thicker on one side, thinner on the other, to try and help restore the native joint line and correct that malversion, if you will. So again, you have these different options. These are some of the fixation options with biologic fluted pegs that you can put bone graft in them, or metal posts that again allow for cementless implantation. Here's a metal back. This is a Lima out of Italy. And here are some of the augmented implants. The StepTech, which is the top one, is stepped glenoid, which has the longest track record because it's been out longest. And some of these newer implants, such as the half-wedged implant by Tournier, and then the ExactTech full wedge implant. And it may turn out that these have different roles, so we need to be familiar with multiple different types of these glenoids, because each glenoid implant may lend itself best to correct a certain type of deformity. So how well do these glenoid implants work? Well, you've got a variety of knowledge sources. You can use biomechanical studies, which, as you know, sometimes don't apply really well or predict performance in real world. You've got clinical studies, but often these are biased and short term. You have systematic reviews, which again are only as good as the quality of the data that's being used to make these conclusions, or these that drive the research. You've got expert opinions, and then you've got national registries, including good registries out of Scandinavia, the Nordic registry, and then Australia. So if we look at the Australian registry in terms of keel versus peg, despite my bias towards peg, there really is no difference through almost 10 years follow-up in terms of the cumulative % revision. So I would say to that you can use whatever you're most comfortable with, and just make sure you follow your patients closely. If you look at convertibility, so the idea of perhaps a modular or metal black glenoid, although it's nice to have a cementless construct and one that potentially is convertible if you need to do a revision to a reverse later on. This has not been borne out in the Australian registry. The revision rates are substantially higher, as shown in blue for metal black glenoids as compared to an all polyethylene glenoid. And you can see through 7 to 8 years, cumulative % revision rate at 5%. The only comment I would make about revision rates, and I think it's important, is there is something called a willingness to treat that can bias, studies that use revision rates as an endpoint. I could make my revision rate 0 simply by refusing to do any revisions. And so you have to take some of this with a grain of salt. But again, the good news here is that you've got 99% capture, basically of a whole continent. So these patients generally are probably not going elsewhere. So you'd probably know about it if they're getting revised somewhere else. Glenoid retroversion, I think Dr. Romeo did a wonderful job about talking about the challenge of addressing the B2 and the B3 glenoid. And their options include high side reaming, or sort of correcting that sort of biconcavity, and then doing a partial version correction, accepting some medialization of the joint line. There may be in the future some thicker polyethylene options that will allow you to restore that joint line, but again, without using an augmented, just a thicker implant. You can use an augmented implant, as I showed in slides earlier, or simply say you hit a certain threshold between age and severity of deformity and just go to a reverse shoulder replacement. But again, the problem with the reverse in the youngest patients, again, there are questions about long-term durability, and some good studies that are emerging about the results in younger patients show that the results are just not as good, whether it's, again, matching expectations, or whether it's the fact that there may be problems borne out because of excessive loading of the implant. Is certainly something to bear in mind. So we know that you can do partial version corrections when you have retroversions up to 10 to 15 degrees, correct it to a few degrees of retroversion and get away with it. But there's still a question mark of what to do when you're talking about retroversions in the order of 20 to 25, even 30%, as you sometimes see with patients this young who have severe primary osteoarthritis or secondary osteoarthritis. And you can do augmented, as I mentioned, try and correct the version or restore the joint line at least part way. And there are some biomechanical and computer simulation studies that show an advantage of augmented glenoids when you have retroversion greater than 15 degrees. But again, We just don't see that overwhelming clinical data supporting this. And there's a long-term data with these newer implants just simply isn't there, although some of it is emerging. And I think we were starting to see some thought is perhaps starting to stratify and consider different augmented glenoids for different glenoid wear patterns. So for example, a fully wedged implant may lend itself to correcting a B3 deformity, whereas a partial wedge or even a stepped implant may fare better for correcting a B2 deformity. And so a lot of it may depend on the amount of the glenoid face that is divided up into the paleoglenoid and the neoglenoid. And we also know there are limits, because if you do really thick augments, we know that these may not last as long and may wear out more prematurely. So with the Exactech device, for example, there's been a study showing that higher failure rates were noted with the thicker augment that tries to correct 16 degrees versus the thinner augmented implant, which corrects at 8 degrees. So just, again, something to bear in mind. And finally, talking about glenoid implants, there is this concept of an inlay glenoid, where you actually put a small glenoid implant, either small or really small. And this may work well for a patient with a focal glenoid defect. But I will submit to you that some of these are so small that even if you place them in the center, you're really covering only a small fraction of the glenoid face. And I question whether this really amounts to a true glenoid resurfacing. It's really a limited or focal or partial glenoid resurfacing. And although the idea about the insetting that polyethylene makes sense, biomechanically, that you're going to be more contained and therefore less likely to have a rocking horse glenoid, for example, over time, or perhaps as a mode of failure. We really just don't know. There's not a whole lot of long-term data. And if you have significant glenoid retroversion, you have to understand too that it's not completely inset, because on the back side and for part of the top and the bottom, it's not inset at all, because you're really right. You don't have bone there to support it posteriorly if you've got significant retroversion. So my preferred method, which is kind of the way I learned from Dr. Madsen, so it was called partial version correction, and still use a conventional implant. And so this is that case that I alluded to with profound loss of motion, 25 years after Bristow's severe deformity. This is not a case for arthroscopy for me, irrespective of his activity level. And you can see here just the amount of just humeral deformity, just giant osteophytes, deformed glenoid as well. And let's see here if this one will play. And hopefully you can see that too. So significant glenoid deformity. But again, if you look at the top left here, the muscle is very healthy. I mean, almost no fatty atrophy or muscle atrophy or fatty replacement. This is not a patient I'm going to do a reverse on, even at age 61. And so, again, Dr. Romeo touched upon this, that, however you do your computer planning, this is a match point through DJO using Materialize-based software. And there are others, many like that, Blueprint and others, that really are very, very helpful to understand how to put a glenoid and make some compromises about, in this case, partial correction. And although the retroversion computed out to 32 degrees, I'll tell you that part of this was exaggerated by this very large heterotopic bone from his old Bristow. So this was, relatively straightforward. We had to make, again, some compromises. The joint line is medialized. And although at 11 weeks, he's still not fully recovered, you can see just like Dr. Romeo's patient with the Riemann run, still not perfectly normal movement, but a very, very happy patient. And I saw him at 1 year doing very well. And he'll continue to improve in terms of strength and endurance for the full year post-operatively. So finally, just a few words about Riemann run before I pass the baton back. This was, again, as Dr. Romeo mentioned, a technique developed by Dr. Madsen right around the time that I was in fellowship, although he wasn't yet using this clinically. And he first tested this in a canine model. And the idea here is that you can do spherical reaming, not just to prepare the glenoid to accept the backside of a polyethylene, but rather forget the glenoid component. We're just going to use spherical reaming that's a little bit more spherical to match the sphericity of your humeral implant or the native humeral head, with a slight amount of mismatch, generally 1 or 2 millimeters, of diametrical or radial or diametrical mismatch. The idea is that you'll get some type of a fiber cartilage surface or smooth surface over time, even though it's raw right at the time of reaming. But you can do partial version correction as shown on the diagram on the top right. There have been good outcomes reported, and Dr. Romeo has a couple of excellent papers that have looked at the results in addition to excellent short and midterm studies by Dr. Madsen and his colleagues. Mike Wirth has also written upon this. Andy Green is getting ready to work on this and submit work related to this. And I've been performing this selectively. It's not a big part of my practice. You have to have the right patient. They're often very resilient, very active ex-athletes who are used to dealing with some level of pain and come very motivated for any type of solution that'll avoid a glenoid component. And so the things you have to bear in mind is that patients don't have that wonderful immediate pain relief that you get typically when you resurface both sides of the joint. So they tend to have residual pain levels at the short and intermediate term, although within the first couple of months it really does dissipate. These patients do tend to get stiff, and although some are very happy with that, others may not be, and so you have to be prepared to doing an arthroscopic capsular release if you're me, or a manipulation if you're Dr. Madsen. And then there are questions about the potential for glenoid erosion or medialization at very long-term follow-up, and some seem to have a little bit more or faster rate of erosion than others. Very long-term follow-up has been lacking. This is actually one of Dr. Romeo's papers, which is a very elegant study matching 24 hemi arthroplasty with a glenoid reaming or ream and run matched with 30 anatomic total shoulders. These were, again, a young cohort, almost the ideal patient at relatively long follow-up of about 6 years. And although the reoperation rate was a little bit higher with the ream and run cohort, you can see that the ream and run cohort was superior in terms of return to sport, even higher demand or upper body specific sports. And although there was some joint line medialization, it made the astute observation that this was also seen in the total shoulder replacement patients. And now that I'm seeing patients in their second decade for follow-up, we do see some remodeling even after we put in a glenoid implant. So I think it's something to bear in mind. So this is a patient of mine who had a significant glenoid wear or bipolar disease, did not want a total shoulder replacement, did not want a glenoid implant. So we did a hemi-arthroplasty and then did a concentric glenoid reaming. He came back the following year to have the other side done. He was a farmer as well as a heavy-duty electrician, and this is exactly perfect operation for him. So here's a case, a more recent case of a 46-year-old man, right-hand dominant, works out with heavy weights, although his office work, does office work for a living. His symptoms worsened after a fall, and he had accelerated loss of motion seen elsewhere. 2 corticosteroid injections failed to provide any relief. And you can see here the progression of his arthrosis between 2018, 2019. And here on MRI, healthy muscles, but advanced bipolar arthrosis and very limited range of motion, not quite the horizontal, and very limited internal rotation. And so, you know, all of these options can be entertained, but I chose to do a ream and run procedure for him, which is through a delta pectoral approach. I tend to prefer a subscapularis peel. We really aren't talking a whole lot about subscapularis management, but really you can make strong arguments for a tenotomy or a peel, maximizing the length, or a lesser tuberosity osteotomy. It's whatever works best in your hands. You have to resect the osteophytes off the humeral head and then do a humeral head resection to expose the glenoid. And even though we're not putting in a glenoid implant, you have to do a periglenoid release, so capsule release, especially if they're concentric. It has to be circumferential. I tend to preserve the majority of the labrum so that it, again, creates a little bit of a bumper on the either end. And then we do this concentric glenoid reaming, generally with a larger size reamer and a larger size humeral head. These are almost always male patients, generally pretty large humeral heads, and aim for partial glenoid version correction. And this is what he looked like radiographically. As range of motion improved, we transitioned to active range of motion. We have to protect the subscapularis. Nothing but a reverse shoulder is going to do well if the subscapularis completely fails, and so that's often a challenge in our youngest patients. Now this is him at 10 weeks post-op. Sorry, the volume is playing, but you can kind of see that still not 100%, and he's a little bit stiff. I will tell you, he gave me a bear hug himself actually hugged me at 6 months because he was back to playing basketball and lifting weights. It's an incredibly gratifying operation, just like the patient that Dr. Romeo showed earlier. Their motion is very smooth. You can see here that he's still not very good range of motion behind his back, but he's still very, very happy. And this will likely get a little bit better over the first couple of months beyond that point. So again, this is certainly an option for our youngest, most active patients. All right, so I'm gonna sort of send it back to Dr. Romeo, and then I can finish off with a couple of slides at the very end. Thank you.
Thank you very much, Samir.
Okay. Can you see my slides okay?
Yes, we do.
Great. So I'm going to move away from the glenoid, which Samir covered very, very well, and talk about the humeral side a little bit more. And my goals are to try to convince you that the most important part of shoulder arthroplasty surgery is getting the humeral head size right and in the right position. And that when you move forward in terms of what innovations are available, you will find out that, in fact, the best stem that's available to hold the humeral head in the right place is a stemless device. So we're all aware that shoulder replacement surgery is meant to improve the patient's comfort level, to improve their motion, and to improve their function. And we've learned that with the properly sized humeral head in the right spot, we oftentimes get range of motion that will rival the opposite shoulder that has no arthritis, and patients get back to all of their activities in a remarkable way. So to do that, obviously you have to be able to see the joint well with good exposure. You've got to get the humeral head exactly the right size in the right spot, and then restore the relationships, which is oftentimes a function of the rotator cuff as much as anything else, and good fixation. But we learned, and really our French colleagues deserve credit for this, Gilles Walsh and Pascal Boileau did a great study and sort of unlocked the secret that the head height to radius of curvature has a relatively fixed ratio in the human body. So you could be a very large person and have a 56 diameter humeral head, and then you'll have a 23 or 24 size to the actual head height. But if you're a small person and your head circumference or diameter is 40, then you may only have a 15 or 16 head height. And this ratio really made a big difference. And we learned early on that if you did the exact same operation the exact same way and you just changed this principle, you got better results. And then based on that, we learned how to do the whole operation a little bit better. So a lot of people figured this out about the same time, but we give credit to those in Lyon and Nice, Michael Pearl in Los Angeles, Joe Iannotti, and then some of our English people. And there's probably others around the world, but those were some of the leading thought leaders at that time. And then as this head size got worked out, people realized, you know, why are we putting in these long stems? We know that this was developed when the hip engineers came over to the shoulder practice and decided, well, to do this and make it work well, you have to have a long stem to make it stable. But humeral loosening at 10 years is less than 1%. And if there is loosening, we immediately think there must be infection or it wasn't put in technically well. So that's never been an issue. And so there's been movement towards a shorter stem, which has gained a lot of popularity. And then more recently, particularly over the last decade, but in the United States, really the last 5 years or so, to a stemless device to see if that really solves our problem with the least amount of bone loss. Now, for anyone that sees these things, we're initially hit with our own personal biases, and some people who like to be innovators will embrace this very quickly. Some people will let it try out for a short period of time, and then they'll adapt it early in their practice. But most people are what we call early majority or late majority type people, and then there's a few, but probably not surgeons in general, who lag behind and want to have as much proof as possible before they know whether it works. And so let's think about this for a minute. Why would you go from a long stem to a short stem? Well, to a large degree, you saw experts that you trusted who said, I've done this and it really makes a big difference for me. And yes, I know I used that other device for years, but this will work well. And many of us switched over to the short stem and have been happy with that result. And that's what we found. So some people said, I've got to be the first. Some people said, this looks really like a great idea. Maybe I'll try it. And they switched over. And so I want you to think about that when you develop some resistance and say, well, I'm pretty happy with the results I have with the short stem or even the long stem. I'm not sure I want to go with this new idea about the stemless, for those of you who have not tried that, because I really think if you accept the fact that putting the head at the right size in the right spot is the most important issue, you'll realize that all you really need is to hold it there for a short period of time, and you don't need a stem in place. And what I'm trying to communicate to is those early adopters and early majority people who then embrace this idea for everybody else. So I realize that not everyone likes this idea, but there's a lot to be said about this. I'm talking about this like it's brand new, but I was at a meeting almost 10 years ago in Heidelberg that Peter Habermeyer put together, and a lot of really talented people there, as you can see from this list, that were talking about stemless head replacement, and they had already been using this for more than 4 or 5 years. In the United States, it's about 5 years old. So this is not new technology. It is in North America, but not in Europe and much of the rest of the world. But we've realized how valuable this can be. So there are a number of short stem implants also that have been out for between 10 and 15 years, some of them a little bit less, and they all have a very similar size. Why is that? Why was that number picked? You would think that it's because there's some kind of scientific study that makes a difference. That's not the real answer. The real answer is that many of these implants are designed in the United States, and our federal our Food and Drug Administration, which regulates the design of stems, said that the initial one that got approved years ago was about 7 centimeters. So if you're going to go any shorter than 7 centimeters, you have to do what's called a independent drug device evaluation. And so an IDE study has to be done, which takes years and millions of dollars. So guess what? Everybody has a stem size that's about the same length for the short stem, so they could get around any regulatory issues. And then gradually, we finally got the opportunity to work past that with European data to use the stemless device. It wasn't based on some type of scientific or biomechanical studies, although people have tried to support the idea with that. It really was a lot to do with government regulation on how these sizes were developed. So we have noticed, though, that there is some designs that have had some problems, and we figured those out pretty quickly. One of the problems with this design was that it would fix very securely distally, and so it would essentially pot itself in the humerus and not have much fixation properly, and there was a high risk of bone resorption or bone reaction. And clearly, the clinical results were not significantly changed while this implant was in place. But the bone resorption is likely to be a significant problem if there's a need for revision surgery. And there's not going to be much bone left, and just putting in another device is not a good answer, because if you lose the tuberosities, you lose the rotator cuff, and even with the reverse prosthesis, a shoulder without a rotator cuff doesn't work as well as one that has one, even with the reverse. So this is concerning because we worry that even though it works well, we're burning a bridge. This was noticed early, and the device was sort of an in-process redesign and had coating put on it. And by report, this has substantially reduced this incidence of radiolucency. So we have to be concerned that we don't have that much information about 5-year follow-up studies on any of the short stem devices, even though we like them better than the long stems, because, quite honestly, they're easier to put in, they're easier to put out if they have to come out. And so we'd like to think that this would make it better for us in the long-term future. We looked at a series of our own devices, a slightly different design, and what we saw early on was with this device, which was essentially just a shortening of the longer stem device. The clinical results were very good, and the loosening rates were also the same, but the radiolucency rates were lower at the 2-year follow-up. We have to do more work to see what it's like at 4 and 5 years to make sure that it holds over time. But at least our early follow-up results demonstrated results which were equal to any long stem device and gave us no concerns of switching from the long stem to the shorter stem device. And in addition, by developing a subscapularis repair technique, it was felt that we were doing a better job in the subscapularis. The follow-up on that is that the subscapularis healing rates are somewhat similar, but we do have a nice strategy in terms of repairing it, and other devices allow for the same thing. We are concerned about the stress healing issue. That remains an issue no matter what implant design that you have. Again, some of them had more radiolucency lines early on, and then by putting a new coating on there and making some adjustments, that's been less of an issue more recently. And so we still have to keep asking ourselves, what's going on at 5 years? And we have some very, very good results, but we don't have a lot of 5-year studies with lots of patients to say this is exactly what happened. We tried to put this together because we want to understand that better. So we recently published a systematic review looking at 13 studies that have been published on the short stem. Again, the follow-up is just right under 3 years, so not long enough in joint arthroplasty to really give a long history in general. Most of the studies were multi-center, and half of them were coming from Europe. And they've all been published in less than the last decade. So we're still learning a lot about that. And many of them, 2/3 of them, were from one implant in particular. So you can see that overall the clinical results, the surgical results, the radiographic results were good, but we are concerned that we don't have enough information to say this is a great answer at 10 years. And so we have more to learn about that, but this is a very commonly used device. And then there were a number of really innovative pioneers that said, you know, do we even need a stem on the humerus? It's a different biomechanics, it's different forces. Could we get away with something less? And the first device that came out was a device that sort of hollowed out the metaphyseal area you see in the uppers, the letter A, and then they impacted that into position, had a very powerful bone ingrowth surface, and that actually was quite stable, but it was also quite difficult to get out, and you lose a lot of bone and even sometimes the tuberosities. And some of the other ones have similar designs. And then you see one of the more popular designs in the bottom right corner that's used, which is a metaphyseal only fixation. And then there's a couple of newer devices like this one in the middle left, which is not only metaphyseal, but also diaphyseal. And so why would we consider stemless arthroplasty? Well, number one, very little bone is removed, so it gives us many options, particularly in these young patients that we're talking about. The anatomic head can be put in the right spot at the right size and held in that position over time. When you take off the head, unlike a resurfacing device, you can get to the glenoid and do whatever you need to do on the glenoid. If you decide to ream and run, or put a graft, or put an actual implant, it doesn't matter. These stemless devices allow full access to the glenoid, and that's very important so that you're not restricted in what you'd like to do for those options. It's nice to have this available, particularly with fracture consequences, because if the alignment is slightly off, you can still get a head in place without worrying about the shaft of the humerus after it's healed. And maybe there's less blood loss and less pain with this operation. And these work because the point of fixation is right close to the center of rotation, so there's very little torque on this device, and it holds it in place for about the 6 weeks that's necessary to get bone ingrowth. And again, these are some of the early devices, now more than 15 years out for some of the early ones, that have had a variety of different methods of fixation, whether it's just metaphyseal or metaphyseal and epiphyseal. Well, I think it's important we have stable fixation. It's nice to be able to use all the qualities of the bone. It's nice to have anatomic head options and have ease of instrumentation. This is the surgery, so the head is cut where it's supposed to be. The actual size of the trunnion is measured and developed there. That is all the rest of the bone preparation that's available by that handheld reaming. A centering guide is placed to find out the depth of the hollow screw that's going to be used. A head cut protector is placed, and you do whatever you need to do on the glenoid side. You come back and take out the head cut protector, putting the centering guide. Then you take your final trunnion, which has a bone ingrowth surface and some spikes to hold it in place. You impact that into position so it's nice and secure. And then you take the hollow screw and you put it down the center and you screw that into position. the amount of force that generates is tremendous in patients with osteoarthritis. There are some cases where the bone's a little soft, and what you can do is take the humeral head that you removed and take that cancellous bone and really stuff or pack the metaphyseal area with additional bone, and then you'll be able to use this implant. And then very nicely here, you have a nice anatomic reconstruction of the device. And this works out very well in more than 95% of patients with osteoarthritis, 95%. There are some systems where they talk about anywhere from 10 to 20% of the time you have to change and go to a stem device. They'll use a variety of different subjective techniques like sticking your thumb and seeing if it goes in and sinks in pretty easily. They're really relying only on metaphyseal bone fixation. This one has both metaphyseal, but because of the incredible compression of the screw, it also uses the diaphysis of the humerus to get very strong fixation. And we have the humeral head on our primary cases to add bone graft, and that makes it so it's a very versatile device. I'm just going to go through the procedure in just a little bit more depth. And so we use a deltoid pectoral incision, which is what we've done for all of the arthroplasty procedures we've talked about. We haven't done anything differently like a superior approach or a posterior approach or any unusual things like that, just standard deltoid pectoral. We do on the subscapularis, the vast majority of the studies that have been done with a tenotomy. Now, many surgeons are also trying to peel the tendon off. So they take more of this tissue and then peel the entire tendon off. And some people will still use a small osteotomy, taking a small amount of bone. We worry about taking any bone and compromising fixation since we're only fixing it in the proximal part of the humerus. And the tenotomy people worry about because they felt the results were not as good in terms of tendon healing. What we've seen with now more than 10-year follow-up from our European colleagues is probably because very little bone is removed, that lateral cuff of tissue doesn't lose its blood supply. And because of that, the healing rates on the subscapularis are very, very high with just a tenotomy alone. When we're done with this operation, you see here, we're peeling this down. That's a very large inferior osteophyte that we're trying to work around. We know that we have gone inferior enough on the humerus when we can see the latissimus tendon. The latissimus tendon comes from the back of the shoulder and it goes forward and inserts on the humerus. So our osteophytes are always in front of the latissimus. Once we see the latissimus tendon, we know we've gotten the bone out of there. And you can see this is about a 3-centimeter inferior osteophyte on this gentleman. And so we're taking this all down because we really want to identify the normal anatomy. But the nice thing is the subscap repair, as I mentioned, is that just side-to-side repair at the subscap at the end has a healing rate of better than 95% based on the few studies that have been out there. Now, I like to do a capsule release early on in the procedure, even before I take the humeral head off. I feel like I get good tension in the capsule. And so here we're pulling on the subscapularis that you see to the right, which is right in this area here. And then what is white is relatively white. In this case, this patient had an inflammatory part of osteoarthritis. So it's a little bit more blood loss than we'd like to lose no more than 150 cc's, to be honest with you. And we'd like to keep it under 100 if everything goes well. And so what I do is I've released the capsule. The muscle is protecting me from the axillary nerve. I proceeded anteriorly up and over the top. And so I'm releasing the capsule up by where the biceps tendon was at. And then I'm going to go right over the top of the subscapularis all the way down to the coracoid process so that I can ensure that I can reestablish the length of the upper part of the subscapularis. And so here, without even taking the humeral head off, I've got that kind of exposure on my glenoid. Once I've done that, I can then put a flat retractor across the glenohumeral joint and I can dislocate the shoulder. So we use this as a shoehorn and we slide that out. And the advantage of doing a really nice release on the humerus and the glenoid at the beginning of the surgery is that you get the whole humeral head to come out of the surgical incision. So that really gives you a great view of exactly where the humeral head is at. And then I'll take a rongeur or an osteotome and clean off the edge. What I'm doing here is I'm trying to catch the synovial reflection and then take all the bone off, just like you do with knee replacement surgery, so I can identify exactly where the patient's non-pathologic cortical rim was actually present. That actually doesn't get disturbed despite the osteoarthritic condition. It stays relatively whole. And once I've done that, I've got to pick out 3 points on the humerus to know exactly where to make my cut. So 1 is up by the rotator cuff, 2 is in the front where I've just removed the subscapularis, and then 3 is down at the bottom. That's where people make the mistake, is down at the bottom, and they cut this too steep, too straight up and down. If you're questioning this at all, there are a number of guides available. Here's an example of a very simple guide that has a little intermedullary component that will help put you in the right spot. The normal inclination is between 125 and 140, so this guide is right in the middle, about 132.5. The key here is not to go below 125. You do not want to compromise that inferior bone. That's critical for these devices that are stemless. So you really want to make sure you do not make too steep of a cut, and preferably stay above 130 in your patients. Once you've identified that, you can do either a guided cut or a free-handed cut. Here's a case where we can see the front and the back and the top and the bottom. And so we do a freehand cut, and we save that bone because we may use it for bone graft. And then I finalize the removal of my osteophytes. The white rim that you see there is the patient's native, normal edge of the bone and cartilage that they were essentially had as an adult. That's what I want to reconstruct. I've got to get the osteophytes out of there to make sure I'm in the right spot. Now, when I do this, the other thing I have to do is that humeral head doesn't go beyond that boundary. There's this belief that I have to cover that entire white spot. It's not true. In fact, the head comes just inside of that and on up. So I think one of the biggest problems with making shoulders a little too tight is being uncomfortable with the idea that you've got to put in a slightly smaller head. And that slightly smaller head actually is the normal anatomic head for the humerus. And so there's a variety of different head sizes that are available. This one here is being matched as a 47, and it has these little spikes to hold it in place. And so we'll line that up, and I'll make sure that it's sitting right in the middle of the humeral head. Now, the humeral head is oval shaped in some patients. It's slightly higher or taller than it is wide, and I'm matching from front to back, which means there may be a little overhang from top to bottom, but it should match up from front to back. That's the key measurement you're looking for. What I just did there is the entire preparation of the humeral canal. I hand reamed that, and that's it. Now I'm using a centering guide, and the purpose here is this guide pin is going to go till it touches the opposite cortex. And whatever size is showing at that point, which here you see the pin is showing you that there's one line remaining, that's the large. There's small, medium, and large, and extra large on this one. We do not want to engage the lateral cortex. That will actually cause stress shielding because it fixes it so well. We take this off, and then we just kind of clean this up a little bit, and then we're ready to go on to our humeral exposure and continue with that. Our glenoid exposure. And I'll just kind of show that briefly. So we'll push this back in. I've got a flat retractor on the back side. We've got pretty good exposure, as you can see here, of the glenoid. What I can do is I can actually come in and do additional release inferiorly and posteriorly to get that either further out the back if I need to. Once the glenoid's in place, I'll come back to the humerus, take out my head cut protector, and put in my centering guide. And then I'll get the humerus so that it's pointing right up towards me, and I'll see this nicely here. So you see the entire proximal end of the humerus. And then we're going to take our final device, which again has the bone ingrowth surface, and we'll put that over the top and impact that into position. Now, this is one specific type of device, but the overall procedure in terms of principles are relatively similar, but each system has slightly different preparation of bone. So make sure whichever system you're using, you follow that. But the key principles is making sure you do a nice release, make sure you prepare for a good subscapularis repair, identify that white rim of the cortical bone, which tells you the normal anatomy of that humerus that you want to match. Make sure you match it from anterior to posterior, preferentially over superior to inferior. Don't make it too big. And then use the fixation the way that it was designed to make sure this is nice and secure. So that is now in place. We'll take this out. If I had felt that that bone was soft or there may be some issues with the screw fixation, I would have scraped out the cancellous bone from the humeral head and packed that in there as hard as I could, and that would really make it nice and secure. Some surgeons actually put bone graft inside of that hollow screw, but I think you can make it so difficult you can't even get the screw all the way down. So I prefer to judge that based on what it needs at the time that we're actually trying to do our reaming. And then once this is all lined up, we'll screw this into position. And quite honestly, sometimes it's so secure, you have to use 2 hands to lock this down all the way into place. And then once that's secure, you don't have to do anything else. Now, a couple of other points. If you decide you're going to use a peel technique where you peel the subscapularis off, you want to have your sutures in the rim of the bone before you put your trunnion down, because it's very difficult to do it after. And that's the same if you're doing a osteotomy. So keep that in mind. Here, I don't have to worry about it because I'm doing side-to-side soft tissue repair when I'm done. And this is what it looks like here. It covers it very, very nicely. And then because it's anatomic, when you reduce the shoulder, the subscapularis length is perfect, and you close it down, and it's a very easy and secure repair. And so that's what that looks like when we're done. And Dr. Hasan and I learned many years ago, if your patient with the arm comfortably at the side can easily externally rotate more than 40 degrees, if you can push on the humeral head and it bounces and it goes back 50% or more and bounces back, or if you can put the arm in abduction like this and internally rotate more than 60 degrees, which is called the 40-50-60 rule of Dr. Matson, your shoulder is balanced, it's stable, and it's got the proper amount of laxity to get an excellent result. So that's what we kind of aim for these operations. Does this operation work? Well, the 9-year results have been published. The 11-year results are in review and will be published within the next 3 to 6 months. But the 11-year results are outstanding. In fact, better than any long stem result. There's very little or no stress shielding. There is not stem loosening. There can't be. And the devices have held their position over 11 years. I think that's really quite remarkable. And I think as this becomes more and more comfortable for surgeons, this is going to be our standard for all patients with osteoarthritis. The overall results clinically, radiographically, especially early on, should be the same as a total shoulder arthroplasty. But again, here's an example 10 years out, and the bone response to the implant is excellent. The glenoid remains in place, and really the results are really spectacular. So we have very, very long-term results from our European colleagues. A final couple of comments about this. Be careful. Here's an example where too much bone was removed, and the implant's not really stable, and it's been impacted all the way over. It probably had a malunion of a prior fracture. These can be difficult cases. It's not always easier. And if you need to use the guide, please do so. Don't overstuff these. You've got to put that humeral head in the right spot, and it's got to be small enough that patients can get their motion. It's really, really important. Make sure you have a good plan for your subscapularis. And then, of course, if you haven't done this, you really should have a backup plan, as short or long stem available, to make sure that you have options. And so resurfacing is another option. My experience has been, and really it's been other people that have done this, is I see a lot of cases where too large of a head's been put into place. And that happens even today. And so I don't do the resurfacing device, and I don't want to be critical of the technique or the implant or the companies. What I know is that in my hands, I can get a reliably great reconstruction using these stemless devices. And I see a lot of cases where it seems like surgeons weren't able to accomplish that with resurfacing. So I would rather do the stemless device. And then again, here's just another example. Do we really need to have a stem? Maybe not, but here's a system where almost 10% you had to go to something else. The other thing, here's an example of a series where a physician does over 350 shoulder arthroplasties a year. So he does a lot of revisions. And like you can imagine, doing a stemless revision is a lot easier than doing one with a stem in it. So he's a big proponent of that and reported his result. That's Jorn Steinbeck. Who has very good results for that, better outcomes when they converted from a stemless device. There's a review article in the United States on this. There's a meta-analysis on this to show this. And these are all just papers to really try to help you understand that, number one, the most important thing is humeral head size and position. It's time to move forward on the innovation curve. This is a device that works and has a long-term record. And the best stem that's out there is a stemless device if it works. And I wish you the very best. Moving along up to early adopter and onto stemless devices. Thank you.
Thank you very much, Dr. Romeo. Thank you, Dr. Samer, for this very nice presentation. Actually, you covered the whole subject to the level that I don't see too much question, because I think everything is covered on this subject. Ali, do you like to go back to your case and do a small discussion before taking some questions?
Hey, so thanks again for the amazing talks. I mean, impressive. Everything's been covered. I think it's really, really comprehensive. We've talked about all the new innovation, both humeral side and glenoid side. I think it's very clear now on the pathology and the treatment. So just before I go back to my talk, I think I come from a school where crazy things have been done. A lot of crazy techniques have been done. And maybe to the audience, this was not covered in this talk, but I don't think you should really take what you will see from my slides as the given, and probably take what's been presented today as the given, as the best possible option that you would have. So I'd go back to my slide and tell you how this patient was treated from my school. So this is, I no longer do this. I think it's no longer reasonable to do this, but so as you can see from this picture, this young patient was demanding more than what he had medically. And at that time, the surgeon who did the surgery, that was now 13 years ago, performed a posterior bone block. So his idea was to recenter the humeral head at that time. And he thought that by increasing the surface area of the glenoid posteriorly, he would be able to center that glenoid. And amazingly, he did that for a couple of years. But after 7 years, the patient was now 46 years old and came with recurrence of pain, progression of the osteoarthritis, and again, posterior subluxation that again restarted his symptoms. And at that time, I assisted in the revision surgery at the revision time, and we did the pyrocarbon hemi-arthroplasty without touching the glenoid. So there was no Riemann run, and there was just a proper, ending up with a pyrocarbon hemi-arthroplasty, which I think Dr. Samer will touch on just at the end of today. It's one of the newer materials that we can use with a similar coefficient to the bone that could help preserve the bone. So you see, this proves that crazy techniques sometimes do not work, and we should really follow what we can do at the time and what we know at the time. And I think this has been very clearly elicited by our colleagues and two teachers that we had today. Maybe I'll pass back to Usama. I think this concludes my talk, my presentation. I'll stop the share.
Thank you, Ali. So, Dr. Romeo, I have two questions right now here. The first question for you and for Samer. In severe glenoid retroversion, maybe like more than 20-25 degree of retroversion, do you combine surgical neck osteotomy of the scapula on the same setting? You do this kind of procedure?
Just so I understand, are you talking about a patient who has arthritis or a patient that presents without arthritis but has significant retroversion?
Yeah, a young patient with osteoarthritis of the glenohumeral joint and severe retroversion of the glenoid.
So I have had cases where young patients, even late teenage years and early 20s, will have significant retroversion without arthritis. And I have at times done a osteotomy of the glenoid. But that procedure has a very high complication rate based on published work and needs to be done very carefully to ensure that you don't make the shoulder worse. In a patient who's already gone on to an arthritic shoulder, then I would typically treat both the glenoid and the humeral side at the same time. And in my hands, I have a more reliable ability to bone graft the defect as opposed to performing an osteotomy and raising the articular surface. So my approach would be to graft or as Dr. Hasan said, you can use an augmented glenoid, but I would correct it by adding materials as opposed to an osteotomy of the glenoid and then treat the humerus as we've discussed.
Okay, thank you, Dr. Romeo.
Yeah.
Dr. Samer, do you want to?
I would agree. I trained with Rick Mattson, who used to do or does posterior glenoid osteotomies, and you have a very narrow margin for success. And it is a finicky operation, to say the least. And I think that you have to look at more predictable options in these younger patients. And I would also err on the side of either doing a partial correction, bone grafting, and then a stemmed or stemless hemiarthroplasty, and then an older patient doing a partial correction, perhaps with an augmented glenoid as well. So those would be my ways of managing it.
And I just want to make one point just in general terms, because Dr. Hasan mentioned about a correction of the version. Most of us will be accepting a retroversion of around 10 degrees. And most of us think that we can do surgical manipulation of the surface of about 10 degrees. So if you add that up, it simply means that when you get 20 degrees or more of retroversion, you've run out of your ability to make a big adjustment with the simple surgical procedure. And now we have to think about larger operations such as a bone graft. But if we have 15 to 20 degrees of retroversion, there are many times with very clever corrective surgery, you get very close to 10 degrees of retroversion, and that's an acceptable level and much less complications and problems with that type of technique.
Okay, very good.
So,
Samer, I think you have some slides you want to present.
Well, just a couple, just to wrap things up. And the only other thing too is, one of the challenges when you're looking at correcting version is you also need to have the implant, your glenoid component, resting on bone. And so one of the other things that you can use to manipulate as well is to consider slightly downsizing your glenoid component, which can allow for better sort of backside coverage or interface with the bone. So again, these are the things where it harkens back to something that Dr. Romeo mentioned as well, which is the importance of preoperative planning, to use whatever platform you're comfortable, or simply study your CT scans objectively and get a sense of how can you come up with a construct that meets all those requirements in order to carry out a successful anatomic shoulder arthroplasty. Ali, what can I say? That talk was was a great case because it brings in a lot of the things that we've talked upon over the past hour or so. And I would just add that there is an interest in alternative bearings, and it is relevant in talking about managing the young arthritic shoulder, because again, you're looking at durability, you're looking at perhaps solving challenges on the glenoid side. The reasoning behind some of these alternative bearings, and most notably pyrocarbon, is that it does have improved wear characteristics and seems to lead to less glenoid wear when performed as a hemiarthroplasty. And so this may be a durable construct in our youngest patients. Let's see here if I, So ceramics is one sort of bearing. There's a couple of these versions out there. I think Maqdes is one that's in use in Europe. The problem with ceramics are they're very brittle, but at least in the shoulder and in the limited experience, ceramic head fractures are actually not that common. There's been more study of pyrocarbonate or pyrolytic carbon, which has very good wear characteristics, although brittleness is still an issue. There are some implants out there that are either standalone resurfacing type implants, but also hemiarthroplasties with heads that are made of pyrocarbon. So here's the Integra, which is a resurfacing. And although I think, again, it's not to be used widely for all the reasons I think that Dr. Romeo avoids these, but there's an interesting study here in very young patients out of Australia with follow-up up to 8 years that has shown very good outcomes. And interestingly, there appears to be this bony adaptation on the glenoid side so that the differences aren't actually any inferior, the results, even in patients with significant glenoid retroversion. And a younger cohort as compared to an older population seem to fare just as well in terms of outcomes. So this is not yet ready for prime time. I think this is evolving data, even though the follow-up's been long. I think the recruitment of these patients has been relatively slow, but it's certainly something to bear in mind. And this is something you alluded to, Ali, that there is some recentering that seems to occur and no further or progressive medialization when you have pyrocarbonate facing glenoid. And there's another study, this is out of Garrett, which is a multi-center study, again, with a pyrocarbon stemmed implant, so pyrocarbon head on a metal implant, again, showing some of the same things that you touched upon. Glenoid erosion did not progress in the vast majority of these patients, and the B2 subgroup seemed to do just as well in terms of their outcome scores. And there is some humeral head recentering noted, so independently, you've got two groups, one out of Australia using an implant that's a resurfacing but made of pyrocarbonate, and another European study with a stemmed hemiarthroplasty with pyrocarbonate head. And I think that when you see studies like this, it just kind of piques my interest. So I don't know if this is enough to sway my interest. And as Dr. Romeo touched upon, it could be decades before we see it in the United States. But the fact of the matter is, it is another way of moving the ball forward. And I think that when you look at younger patients that are hoping for an implant that'll last, 40 or 50 years, durability and taking care of both sides of the joint with durable constructs is the way to go. And if you can get the glenoid to remodel without an implant or with limited treatment, then that is something to bear in mind. So that's really all I had to say. And again, an honor to be a part of this panel and this webinar, and I can't thank you enough.
That was a cherry on the pie. So I think that is very clear. Thank you very much for this very nice talk. If I may just resume that the subject of an arthritic shoulder in a young patient is a very difficult subject to treat. These patients are high demand and will probably come back to see you in years to come if you are young and maybe will see them in the future. The progression seems to go for more osteoarthritis as time goes on, as the years go on. If you start with a posterior subluxation, you will end up with more posterior subluxation and so on, and you cannot stop the process of degeneration. I think Usama wants to go to two questions more, the last two before we end. Is that right?
Yeah, I think so. There's one question for both of you, for the panel, is asking about the tensioning of the subscap after the surgery to avoid the posterior wear on the glenoid side. Dr. Romeo, how do you judge this tension is good, this is not enough, this is over tight? How you judge this intraoperatively?
Well, I've been doing shoulder replacements now for almost 30 years, and this was a very important issue many years ago when we thought about the shoulder as a two-dimensional structure. And the way that we were doing the operation is that we would tension the soft tissues by the neck length of the humeral head. And we learned 15 to 20 years ago that that's actually not the right way to do things. We need to put the right size humeral head with the right size neck in place. And when we do that, the operation actually becomes much less of a challenge with regards to the soft tissues. So to answer your question, the reality is when I do a stemless device, I just repair it back anatomically. I don't do anything unique or special or measure anything. As you saw, what Dr. Hasan and I both learned from Dr. Matson when he was trying to figure out those soft tissues, is what we call the 40, 50, 60 rule. So 40 degrees or more of external rotation, but this is even before repairing the subscap, and the shoulder stayed in place. 50% of posterior translation or more, and then it comes back in place, and 60 degrees of internal rotation abduction, and patients would get a very good functional result with what we call sort of the type 2 or the second level. Now with regular shoulder replacements, we just, I take down the subscap, I do a release of the anterior capsule, and I sew it back anatomically. I make no additional effort to understand the length, the tension, or anything else. I just take it down, release the capsule, and sew it back anatomically, and it works wonderfully well as long as I have the right humeral head in place.
Okay.
Yeah, very little to add from my end. I do resect the anterior capsule in some patients, but I preserve the lateral portion because I'd like my subscapularis to be a thick layer. So where it's not easily separable, I typically sort of leave it alone. But I think that the point of doing a 360-degree subscapularis release and perhaps paying close attention on the superficial side to respect the innervation of the subscapularis muscle, but I think a release is the key. I think the opposite situation is one that we sometimes are challenged with, which is occasionally we'll have patients that are so contracted, their subscapularis is so shortened that because of either prior surgery or what have you, or a lot of obligate translation where the humeral head is subluxed, and sometimes you have to be creative in terms of how you manage that tendon, whether you do a lengthening or whether you accept and place it in a little bit less external rotation, or whether you simply abort to a reverse shoulder in the oldest patients. But that's the scenario. As far as over tightening, I make no attempt to over tighten. I just try to repair it where it lies.
Okay, very good. There is another question, Dr. Romeo. You nicely mentioned the option of treatment in young arthritic patient before going for the arthroplasty. One of this treatment is the arthroscopic debridement, capsular release, doing subacromial decompression. If you see a patient with this, you're going to do this procedure, the capsular release and subacromial decompression, and there is a small cuff tear on the same patient. What would you do for the cuff? Do you repair the cuff for the future arthroplasty to be much easier? Or you just leave it alone because the patient, you need this patient to move his shoulder and do range of motion early? What do you do?
We know from the literature that when you encounter a small degenerative rotator cuff tear at the time of anatomic shoulder arthroplasty, whether you repair it or not does not change the outcome for that patient. And so we have to be careful because we don't want to say that a patient that has the entire supraspinatus with a lot of fatty infiltration, a supraspinatus tear with fatty infiltration is the same. What we're talking about is that a significant number of patients, maybe up to 15%, will have at least a partial and a small full thickness tear at that anterior 1/3 of the supraspinatus. And in general, it does not need to be repaired at the time of shoulder arthroplasty. If I'm doing a arthroscopic procedure, then most likely I have a preoperative magnetic resonance imaging study, and I'm aware of the status of the rotator cuff. If the patient has a small degenerative tear and I'm treating the arthritis, I will leave it alone. However, if the patient has an injury superimposed on their arthritis, and so they have a good muscle pattern, but they have a small tear of the rotator cuff that's related to a specific event, but we're also treating arthritis, in that case, I will actually make an attempt to repair that tendon and try to restore that back to the pre-injury level. And I have to be more involved in the post-operative recovery because I need the patient to move, but I have to protect the tendon repair. And so this is unusual. Most of the time, they're just degenerative changes and we leave them alone. But in those few cases where we have a significant tear that's involved, but we're treating the arthritis, I will repair that and adjust the therapy.
Nothing to add from my end. That was spectacular. And I think that there's good emerging data. We've kind of, the pendulum has swung in terms of rehab, but there's good current data that tells us that we can move those smaller cuff tears relatively quickly. And we have to protect them. You do active assisted movements in the plane of the scapula, but I think that what you don't want to do is do that repair and debride the arthritis or treat the arthritis and then stick them in a sling for a month. I don't think you're doing the patient any service. So fortunately, there's good data to support moving them early and allowing that joint to sort of heal but you have to, again, watch over that patient closely, as Dr. Romeo mentioned. Couldn't agree anymore.
Yeah, thank you very much for the answer. Ali, do you have any question from your side?
I want to give these guys a break. Thank you, guys. I think that's excellent. That's more than we intended to have.
Well,
So I'm sorry for the people we could not have answered the questions, but ladies and gentlemen, this was fantastic. I don't know if the audience enjoyed this as much as I did. I learned a ton. Thank you guys for being with us, supporting us for 2 hours. This was quite a long seminar, and I think it's very conclusive. I would probably see it again tomorrow to really understand everything again. Usama, thank you for organizing this. Dr. Samar and Dr. Anthony, thank you very much for joining us. We hope to meet one day live in Dubai. So let's try to arrange that. Thank you very much for supporting us and giving us all the talks.
Thank you.
Back to you.
Romeo, thank you very much, Dr. Samir, for this very nice presentation, and hope to see you soon physically next year in Dubai shoulder course. Thank you very much for your time today. Please stay safe and stay well. Thank you.
Thank you.
You as well. Thank you again. Cheers.
Good night.
Good night. Bye-bye.